Good afternoon and welcome to our event, Give It Your Best Shot, Reaching the Vaccine Hesitant Young. I'm Brian Simpson from the Johns Hopkins Bloomberg School of Public Health, where I edit Global Health Now. As more folks join us, please let us know in the chat where you're tuning in from. And it's great to see participants from so many different places. We created this important conversation today through the Campus Consortium partnership between the Bloomberg School and the Pulitzer Center. Via this partnership, we convene journalists and public health experts to learn from one another and to reach broader communities with important insights. Okay, a few quick logistics. After our panelists talk, we'll have time for questions from the audience. Please click on the Q&A icon to add your questions at any time throughout the remarks. Please use the chat icon if you're having technology issues or want to share comments. Note that all attendees are muted, but if you cannot hear us, please let us know via the chat box. This session is being recorded and will be posted online for others who could not join us today. And finally, please stay online after the session to participate in a brief survey. Now I'd like to introduce our moderator and today's first presenter, Rupali Limaye, Director of Behavioral and Implementation Science for the International Vaccine Access Center at the Bloomberg School. Rupali, over to you.
Thank you so much, Brian. It's wonderful to be here. We could start sharing the slides, please. Great. Thank you so much. Thank you again for joining us today. We're here to talk about what are some of the best ways that we can reach the vaccine hesitant young. And as Brian mentioned, I'm faculty in the School of Public Health at Johns Hopkins University, as well as on the management team at the International Vaccine Access Center. If we can go to the next slide. We're going to start with just some few opening remarks to set the stage before we hear from three excellent presenters. First, what is driving vaccine hesitancy? So prior to COVID, there were essentially four reasons why individuals had concerns about taking a vaccine. These focused on ingredients from a vaccine, the schedule, a misperception of a link between vaccines and severe adverse events, as well as low levels of risk perception, i.e. people did not feel they were susceptible to any type of vaccine preventable disease. However, that has shifted quite a bit within the context of COVID. So with regards to why individuals are hesitant to take the COVID-19 vaccine, we've seen essentially three primary reasons why. The first is distrust and lack of confidence. The second is misinformation and disinformation. And the third is polarization. With regards to distrust and lack of confidence, to illustrate this further, an example that I can give you is that I've been holding question and answer periods with African Methodist, Episcopalian, Zion congregations. And over the last 12 months, I've met with approximately 50 of these congregations in a number of states. The key concerns that have come out from these discussions is that individuals are very distrustful of the vaccine development process. This is timing of the process itself, as well as how participants were recruited. In addition, there is distrust towards the healthcare system due to a history of medical experimentation and current issues related to racism and discrimination. With regards to confidence, the key question that I receive after facilitating these types of sessions is the vaccine safe for Black people? And in addition to this, is the vaccine safe if I have some other issue, i.e. comorbidity, perhaps diabetes, high blood pressure, etc.? The second issue related to misinformation and disinformation is what we're seeing is that when people spread misinformation, they often believe the information that they are sharing. This is a key issue with regards to social media. Disinformation, on the other hand, is crafted and disseminated with the intent to mislead others. An example I can give you here is that if a political leader claims that COVID-19 is no worse than the flu, despite knowing that this is not true, that's disinformation. However, when an individual sees this and then shares it and believes it, that is misinformation. The third issue as to why we're seeing hesitancy to the COVID-19 vaccines is polarization of attitudes. What you're seeing here is essentially a cluster of individuals on Facebook. The blue dots represent individuals that have pro-vaccination attitudes. The red dots represent individuals that have anti-vaccination attitudes, and the green dots are undecided. What we can see here is that there's not a lot of mixing, meaning we have created echo chambers with regards to vaccine attitudes. So how should we communicate, especially in this fact-resistant world? The first thing to think about is using something called the availability heuristic. What that means is that it helps us think about and estimate risks or probabilities for an event to occur. For example, we are much more likely to remember if a plane crashed because we'll hear it on the news versus when you had a safe flight. So it's important when we talk about vaccines and risk communication that we think about heuristics that people can easily relate to think about probabilities and odds. A second issue is that it's very important to not correct misperceptions. I think this can be challenging for many. The instinctive response is when we hear something that is not true, we definitely want to provide correct information. However, we know that this can backfire and lead to something called a boomerang effect. Instead, the key thing to do here is when you're confronted with a misperception or misinformation from someone, what you should be doing is essentially pivoting the conversation to focus on the disease. And what I mean by that is you can talk about severity of the disease as well as susceptibility of the disease. Finally, the last thing that you can do is use something called defaults or presumptive communication. The majority of individuals here in the United States, as well as globally, if they are offered a COVID-19 vaccine, will accept that vaccine. As a result, it's important to stress that vaccination is the norm. So when you're having a conversation with someone and perhaps it's time for them to get a vaccine, you should automatically assume that they're getting the vaccine and make it the default option. Thank you so much. I'm very excited to introduce our other panelists that will be joining us today. So medical journalist Caleb Hellerman, who's director of the CNN BBC documentary Race for the Vaccine, and medical journalist at the Global Health Reporting Center, will be joining us today. In addition, we are joined by award-winning filmmaker Janet Tobias, who's the executive producer of Race for the Vaccine and the Global Health Reporting Center's CEO and founder. And finally, we are joined by Nick Moran, who's associate director of audience development, Johns Hopkins Bloomberg School of Public Health. I'll turn it over to Nick.
Hi, everyone. Glad to be here today. So we will start just introducing the School of Public Health social media. So as you can see here, we are fortunate to manage 5 English language accounts, 1 Chinese language account, and combined, we've got close to 1 million followers. We publish 65 posts per week on average, which reach a combined 4.5 million people each week. And over the last year or so, we've gained about half a point in our follower growth each week. And the types of posts that we are publishing primarily have to have 3 different flavors, and they're represented here, ranging on the left from what I would consider to be pretty straight-laced, information-heavy. The middle is a bit more engaging and playful in the design layout. And the third on the right is what I would consider to be a little sillier and eye-catching. But the through line with all 3 types is they're always colorful. We always aim for something that's visually arresting to stop people from scrolling to check out. And then we also are always staying on message. And so a couple examples, just 2 quick ones of successful posts. So when Johnson & Johnson announced, or when the CDC rather announced a pause to administration of the Johnson & Johnson vaccine, we published an explainer essentially explaining that this is an indication that the system is working, that safety is being considered very, very closely, and that people who already had received the Johnson & Johnson vaccine should not be panicking necessarily. And this post on Facebook alone reached over 60 million people organically over the span of about 4 or 5 days. And it received over 1 million engagements, got tons of comments and everything. We know at least one of the accounts that engaged with it is someone at the CDC, because as I put in the chat here, they published a very similar designed post a day or 2 after we did. So we know it works. And so the next example I'll show is we had a post about the flu vaccine and getting the flu vaccine during the winter months of 2020 when COVID was really ramping up in the US in their first wave. And what we know about this video, so obviously it performed very well, it got 2.5 million views. But what we know about it, which circles back to something Rupali was saying, is that the first soundbite in this video is Jennifer Gerber, who's one of our alumni, saying, the flu vaccine cannot give you the flu. And when you start with a direct, not necessarily strong refutation, but a direct address of an FAQ, you hook people's attention in a way that you wouldn't if you just began with a cold open of, get your flu shot or something like that. And here's the video if you want to check it out. And so in general, I'll just walk through a couple things about how we produce our content. And so, like I said, we stick to messages. We have at any given time 4 or 5 key messages that we are keeping in mind. So for much of the past year, for instance, in the US, while we're dealing with COVID, a key message might be, schools can open safely. And what we do in the third bullet point there is ladder the content. So we, instead of just producing something that says schools can open safely, we might begin with, COVID is dangerous. And then we might, in a subsequent post, do the vaccine is safe. And then in the third post, we might do ergo, getting the COVID vaccine makes school safe for a teacher, for instance. And so that's sort of how we think through it. We don't, rather than have one piece of content address all elements of an issue, we atomize it and do one piece at a time, always sort of building towards this key message. And so the other thing we keep in mind, especially with the US during calendar year 2020, was there was a really enormous need for clear news you can use style guidance, because a lot of the standard agencies were not necessarily providing this at the time. It was either muddled, or it was changing week to week, or people sensed that it was changing week to week, even though it wasn't necessarily. And so we try to ground it in very colloquial, very easy to understand news you can use, like the middle post here, get vaccinated even if you had COVID, here's why. Anyone can understand that. It speaks to an FAQ that people have. And so that's sort of our other thoughts. And like Rupali said, we do have to once in a while pre-bunk or debunk misinformation. It's something like on social, we have a front row seat to a lot of this misinformation out there, which a lot of it is in good faith. A lot of it is someone might have just misunderstood something or gotten only half the story, or they're maybe 3 or 4 news cycles behind where the science is. And so we take it seriously that we need to, as a reputable source, correct some of that. And so we'll frequently do that too. So picking a platform, the reason we are on the platforms where we are, so of the main social accounts, the ones that we use most frequently are Facebook, Instagram, and Twitter. Is simply put, that's where the users in the US are. But when you are operating at a smaller scale organization, I think that the main things you want to consider when choosing where to go is you really want to go where you can add value and where you are operating in the vocabulary, in the community norms within that platform. So on the right here, we have an Instagram comment. One of the things our account has been known for is engaging with our comments in this way. And so often the reason for doing that is because there's a large number of people who use these platforms who actually get more information from the comments on posts than from the posts themselves. And so you're not necessarily just talking to that person, you're talking to potentially thousands of other people that are coming through the comments. And also, I think one last point on this slide is that when people are choosing their platform, it can be alluring to go after scale. It can be alluring to say, I want to be on Facebook because everyone is on Facebook. But that's a bit like saying, there are more people in Tokyo than there are in Baltimore. Should I be in Tokyo? No, I don't speak Japanese. And so you need to sort of understand your audience and where you can contribute in a way that's meaningful. And then the biggest North Star for our content, and the thing that I think has worked the best over the last year is we sort of have taken it as a given that we benefit when peers share our content more than when we just broadcast it out. So on the right is a post we put out when Drake released his new album about how pregnant women should and can get the vaccine safely. And that was shared by hundreds and thousands of people. And the reason for that is because it's interesting, it's not overly branded, and it's not complicated. And it ends up reaching far more people that way than if we had just gone after our own audience. And just proof is in the pudding. This is our audience growth over the last calendar year, going back farther to March of last year when COVID began and we adopted these strategies. It's even more.
Great. Thank you so much, Nick. That was really interesting. I have one quick question for you before we turn it over to Caleb as well as Janet. Just curious, because I know you all deal with the number of followers alone is just immense, just seeing how many you have gained over this last year. With regards to misinformation, I'm just curious, do you think, what is the role of when we're engaging with individuals that might have misinformation? What do you think the role of empathy is with regards to the communication that you all do?
Yeah, it's a great question. I think it's very similar to when you deal with misinformation in your everyday life, where empathy is really important. You need to acknowledge that you hear their concern, that they're really, especially when they're operating in misinformation as opposed to disinformation, that they're really primarily concerned with their own safety or the safety of their family. And they're coming from that position. And so you need to address and acknowledge the fact that they're coming to you in good faith with this perception. And in plain English, you need to sort of explain the rationale of what the facts are, but also try to ground it in, try to make it in the context of what they came to you with. If they're worried about, if they think it's safe to go to a sporting event, you can refute and say, like, it's not the sporting event itself, it's going to the bathroom at the sporting event, sort of thing, and just make it realistic for them in that way.
I think an excellent point, and it's so important to, I think, totally, I agree with you that they are coming from a place of concern, right? They just want to protect themselves and their families. So very excellent. Thank you so much, Nick. I'm going to turn it over to Caleb as well as Janet. So over to you, Caleb.
Hi. Well, thanks for tuning in, everyone. And it was great hearing from Nick. Well, I'll back up. Jen and I work with the Global Health Reporting Center, which is a relatively new nonprofit devoted to basically covering health and public health, both in the US and abroad. We have a Race for the Vaccine, the film I co-directed and Janet was EP of, was sort of our initial flagship effort, and it was really hitting on a lot of these topics. And I like the term pre-bunk. We knew there was going to be a lot of skepticism about the vaccine, or a lot of discussion about the vaccine. So we followed that over the first several months of development to get into it. Our new project, our latest project, is a show for PBS Digital Studios called Vitals. I guess maybe just as a little preview, I have a little clip, this is the Instagram post we did, which is like about a 40-second excerpt from our first episode. So this will give you a little sense of who's on screen.
I read a poll saying that nearly half of all parents would, quote, wait to see how it's working before vaccinating their children. And I gotta say, as a nurse, that makes me anxious, but as a parent, I totally understand.
And I think it's unfair to label everyone out there who has a question about vaccines as anti-vax. It just alienates them. And we wanna know that these vaccines are safe, and like, what's happening in those clinical trials? When and if I give my kid a vaccine, like, is everything gonna be okay? Well, here's how it goes. The process for testing vaccines in kids is essentially the same thing as adults. Companies were testing the vaccine out on teens back in fall 2020, but they waited for more data before expanding on to testing younger children.
So, this was from our first episode, which launched 2 weeks ago. Today's our second episode, was about kids and COVID vaccines. Like, what's up with children and the vaccine for children? This is not how the actual episode began, but this was something we put out on sort of our primary outreach program, medium, Instagram, to drive people to watch the full episode on YouTube. We're going where the audience is. All the PBS Digital Studios shows, the primary platform is YouTube. They're available on PBS and Facebook, in some cases other places, but the bulk is on YouTube. And some of the more popular science shows are like 4 million subscribers, 3 million subscribers. We're just starting, so we aspire to get there. We're the first health show they're doing. That's what we wanted to be there. We talked about meeting a need. We wanted to be there in this space where there was an audience that's clearly very hungry for good, strong, trustworthy science type information. We wanted to do a medical show. One of the things that's really important that Janet and I talk about a lot is, who are the messengers? We talk about people are less trusting of official sources. They trust their friends and family. they also, I think there's stereotypes that hold back people's trust. People are at least a large segment of the audience is looking, just instinctively distrust people who are much older than them, who just look like stereotypical old person doctor in a white coat. So we really, when we were casting for this show and also for a television project we have in the works, we're looking for people who are comfortable in this medium. They are used to being out on, they're used to the video world, they're used to a young audience. The tone is just more casual, more irreverent, while we still have the same kind of editorial standards you would expect on a film for BBC or PBS. This is Alok Patel. We see him with his eyes closed. He's a pediatrician out in San Francisco. Sheena Williams, you also saw, she's a registered nurse in Philadelphia, who we first saw because she's a great communicator on Instagram, talking about her experiences during COVID there. So we felt like, in a lot of ways, the messenger is critical. I mean, that people just aren't going to listen. They just tune out certain forms of information. I think that's also the reason to be doing a digital show and not just be doing Q&A on CNN or PBS somewhere. Those are very valuable, but we want to go where the audience is, or at least where a large segment of the audience is. Clear, racial, ethnic diversity is critical. It's going to be a big part of the topics that we cover going forward. I think we wanted to make sure that our hosts and correspondents reflected that. And I think that I'm getting a little bit of a crash course of doing this. I've not produced a digital show before, and a lot of things that Nick was just talking about. I think that not showing empathy to people and understanding the place where they're coming from, if they're mistrusting of information, I think is really critical. So I think tone is something we're really striving to keep that tone. We're trying to be a little more humorous whenever we can. We're going to take on serious topics, but I think humor always helps people relax, helps them pay attention. And I think it's also important to know that we're in this for the long term. People just don't trust you right off the bat. They're going to trust you if they see you week after week coming back and listening to their comments and being relatable and being responsive. And I'll kick it back to Janet to talk a little bit more about some of the other work the GHRC is doing.
I read a poll saying.
And the point I would make here is that it is personal and emotional stories that often change people's minds. The head of communications at Wellcome Trust and I had a long conversation, and he said, my hardest job is to convince scientists and doctors not to tell people another data point, that we need to tell them a story. And I still have Shannon's t-shirt made into a quilt with other t-shirts to remember her. And our staff, which had a lot of young people who were not sure they should get flu vaccines, all got flu vaccines after we did this film. So Rupali, it's that. I wanted to just blow through the power of personal story, how analogies are really important in terms of rumors like viruses. And then the last one is people tend not to forget the bird market.
No, thank you so much, Caleb and Janet, for sharing really I think some beautifully well-told, compelling stories. I just have a couple of questions if I can ask here before we turn it over to the larger Q&A. So I think, Janet, you made a point with regards to that scientists really like their data points. And as a scientist myself, and with many colleagues that I work with, this rings so true to me. And I guess the question that I have for you is that if you are a scientist and you're trying to think about ways in which we can communicate about vaccines, and you're new to storytelling or to using a narrative approach, what's sort of the one piece of advice that you could give folks, as they're thinking about this and they're thinking about using this type of an approach that maybe could just help them get started? Because I think many scientists see this as really daunting. What you all have put together is beautiful. And I think a lot of scientists would say, I'm not equipped to do this. And so I'm just curious if you all have any sort of pieces of, key sort of takeaways that you can help folks, because we have many scientists also joining this webinar today.
I would say that we all live in a world where we know people and know stories. We grow up learning how to tell stories. That's how we teach each other and share. And so everyone probably can will know someone who has a story in relation to vaccine hesitancy, or someone that they know who is very sick if they didn't die. And I think a single story is really powerful. And the more you can tell details around that, that Shannon was an artist, that she wanted to be a comic book designer. And then people remember she's not just a name, she's a 17-year-old who could have grown up and worked on Marvel or anything. And you're gonna then feel her loss that much more.
Excellent, excellent advice. I think something to consider. And I was curious about that in terms of, do you pull together a number of stories, but essentially saying, focusing on one, getting into that detail, being able to connect with your audience, like in that first one. I think it's a really nice illustrative example. I don't know, Caleb, if you have anything else that you want to add, that perhaps advice that you can give to scientists that are sort of new to this type of communication with regards to storytelling or narrative approaches.
Right. Well, I think Janet put it well, that is, people remember the details. I mean, I think it's something just to keep in mind that people, I think it's been driven home more than ever that the vast majority of people, even very well-educated people, do not really come to their opinions and beliefs through a systematic, rational decision-making process. And I think we just need to recognize that. That's a fact. We're not going to change that. And I think as communicators, it's incumbent on us to not manipulate that process. We do a tremendous amount of work in preparing and finding stories that are representative of the factual information we want to convey. So it's a real responsibility on us as science communicators, or certainly as scientists. But at the end of the day, what people remember, they remember the anecdote. They don't really remember the data set.
Absolutely. And I think, Janet and Caleb, you also touched on another point that I quickly want to go to a question to Nick, if I can. This idea of the messenger, right? The way that you showed those 3 clips, there's very distinct messengers that you all have utilized in this work so far. And I'm curious, Nick, on your piece, thinking about this as a messenger with regards to the social media platform, what do you think we need to be really doing, moving forward, if you kind of had just all the resources under your belt to really engage with young people, right? Like, what do we need to be thinking about when we're thinking about the messengers that we're currently employing, and how could we improve on that? I don't know if you have thoughts on that.
Yeah, it's a great concern. It's top of mind for us a lot. We've found over the last year, one tactic that we've had a lot of success with is, ordinarily in a normal year, the people from Johns Hopkins who are on the TV talking to media are faculty, and faculty are fantastic. But for reaching young people, in particular, young people who may be from underrepresented minorities, we've found more success going to our doctoral students and getting them to, we've done 2 videos now where it's doctoral students and candidates answering questions that our social media users sent in about the vaccines. And when we do that, we not only bring the age range down on a lot of these people on the camera, but they also represent more communities, and they tend to just speak in the vernacular and conversations that the audience is. And that approach works. These are people who, probably have relatives who have the same concerns, and they're basically just giving the answer that they would give their cousin or something to everyone. And doing that, broadcasting that in a way that reaches the young people is really successful.
I think it's such an important point, Nick. I think those of us that are faculty members, we speak in this very scientific ease, if you will. And I think a lot is sometimes lost there with regards to how to we really connect with the audience. And so I want to thank all 3 of you, Nick, Caleb, as well as Janet, for giving us those really nice, beautiful presentations to get us started, as well as I think some very key practical things to consider if folks are trying to think about how do we use a more narrative type of response to engage with our audience and to think about our messenger and really empathize and think about where people are coming from when we're developing these types of stories. I want to quickly turn it over. I'm very excited to move into the Q&A session, and we're excited to have so many participants here joining us today. I'd like to introduce your moderators for this next section. So Kiana Lewis is a doctoral student in the Department of Population, Family, and Reproductive Health at the Johns Hopkins Bloomberg School of Public Health. Welcome, Kiana, and thank you for joining us. In addition to Kiana, Aneri Patani is joining us. She's an MPH student here at the Bloomberg School of Public Health. She is also a Bloomberg Fellow, and she's a national correspondent with Kaiser Health News. So we're really pleased to have both of these individuals here with us today. I'm going to turn it over to Aneri to ask the first question.
Thanks so much, Rupali, and thank you everyone for joining and for the great presentations. I wanted to kick it off just as we're talking about young people and young adults in particular, talk a little bit about risk perception. I think we know, for a lot of adolescents, young adults, their brains are still developing. Risk perception can, be part of that. And so they might feel they're invincible. So how do you address that when talking about vaccines? How much should risk or odds be part of that communication, or are there other factors that are more salient? And I'll open that up to all of the panelists.
Well, I think the first thing in thinking about this is, if you're talking about a one-on-one conversation, or if you're sort of looking at the comment section on a show like Vitals, it's very important to listen. I think to not be just shouting off into space. You want to hear what are the concerns of the person or the people in front of you. I think on one level, I think it's important to be very honest. You can't dismiss what people's concerns are. I mean, you have to acknowledge, yes, the risk of COVID is less for younger people, because otherwise people just, if you don't acknowledge something like that, you're lost. But I do think it's important to bring in, you might adjust the message for a different audience and say, look, it's not just about yourself. If you go to school, you have teachers who are older than you, you have parents, you have an older community of people who are vulnerable. And also you don't know who necessarily is the most vulnerable. There's a huge population of immunocompromised people out in this world right now that we've become more and more aware of. So I think that playing to that altruistic element is something, that's a good card to play with people who are like to see themselves or do see themselves as more invincible.
Thank you. My next question builds on Nick Moran's comments about engaging youth, but really is for all the panelists. So the Johns Hopkins Center for Adolescent Health is leading the CDC-funded Voices on Vax initiative with the goal of increasing COVID vaccine confidence and uptake among Black families in Baltimore. They are using a youth-mediated health communication strategy where youth serve as health ambassadors to engage parents and their family members in COVID vaccine education and trust building. How would you recommend engaging youth in developing and disseminating the COVID messaging in your organizations, both nonprofits and like university settings?
I can take a first swing at this one. So one tactic that we use whenever we're doing any sort of content that could verge into a pop culture reference or a meme or something that we, are designing with a youth audience in mind is we find it really helpful to have a series of gut checks. A couple people to tell you, A, is it using the meme even correctly? And then B, think through the elements of it that maybe someone not living in that world would not necessarily think through. So is there Squid Game is a very popular thing on Netflix right now. Is a school the right venue to make a Squid Game meme where the show is essentially about people locked into debt? No, it's not. And so that's sort of the thinking that you need. And so to bring that back to the Voices on Vax crew, youth ambassadors play a key role in making in basically wayfinding which the appropriate cultural context for the right content. And also on top of that, what's the appropriate content that you can make for their little specific micro community? Maybe something that plays well within that young person's youth group is different from what plays well with that young person's demographic in the entire city. And so having them help with that is really an invaluable role that they can play.
Yeah, I would completely agree with that. A lot of that is about listening, and the specificity of these subcultures and youth culture. I think it really can't be overstated. And if you kind of blunder in and don't road test these things a little bit with the people you're trying to reach, you're just setting yourself up to be mocked and worse, completely ignored. It'd be great to be mocked if everyone was paying attention, then they might listen to your message. But I think that's really can't be said too much.
So I wanted to share a question from the audience here. Is there any information about vaccine hesitancy on college campuses specifically? Are vaccination rates on college campuses consistent with national rates?
Can comment quickly on this if none of the panelists would like to take this one on. It's a great question, Inari, and what we're seeing essentially is around the time when mandates started to become much more popular in this country, I think many colleges have now instituted a mandate. So in general, we're seeing higher rates of coverage and acceptance at college universities. And there's a number of reasons for that, why I think colleges took that step. You're living in congregate settings, right? There's young people that are mingling that aren't necessarily going to adhere to social distancing measures. And so what we've seen generally is that compared to the non-college population, say 18 to 22s, is that those that are in college are much more likely to get vaccinated compared to those that are not in college. And I think generally when you think about the breakdown of age group with regards to acceptance, the 18s to 29s in general are sort of on the lower end of getting the vaccine if we think about vaccination coverage in the United States.
One thing to quickly add related to that point is back to the trusted messengers tactic. So we've developed a series of posts around, I've gotten the vaccine, how do I talk to my friends and family about getting it? And where we've found the most resonance with that content is when we deliberately pay to target that stuff into college towns or college communities and that demographic, thinking through, this group's probably been vaccinated. They know it's probably no big deal in terms of safety at this point. They've got direct experience to it. They can now talk from a position of knowledge to the people they talk to. And so targeting a school with a vaccine mandate in a state with low vaccine uptake can actually ripple out, and now you're reaching people who live in that state. And so we've found a lot of success with that.
We have a question from a person studying public health in Sweden, where they said that the vaccine against, where vaccination against COVID is fairly high at about 70% of the total population fully vaccinated. But many young people are refusing the vaccine, often citing a preference for natural immunity. The country has an attitude of protect the risk groups only. And with the flu vaccine, you need to pay if you do not belong to this risk group. How would you recommend reaching those people when the government, to a degree, downplays the flu and COVID?
I'll be really interested to hear the answer to this, because Sweden has been such a talking point in this country. People pointing to it as a example or counterexample, depending on the moment. I don't know. I don't know anything about Swedish youth culture, which I think speaks to that. This would be a great study to do. But I think that preference for natural infection or even there is an element to vaccine hesitancy and resistance that's very heavily leans on just distrust of pharmaceuticals in general and medicine in general, which obviously plays into a larger trend than the specific vaccine. It's just sort of a gut check. People like to think natural sounds good, even if it's naturally being infected by a terrible virus.
And I would just add that I think the way to reach the young people in Sweden is to tell a Shannon-like story about someone in Sweden. Is that you're not going to reach them by telling stories about people who are a lot older. You're going to need to reach them with the messenger being someone their age and the affected person being someone their age too, so that they can feel and see that as an example.
Thank you both. Dr. Limaye, there's been a request for you could you repeat the strategies that you shared at the start about reaching people who are vaccine hesitant? Maybe just a recap of some of the main points there.
Sure. Yeah, no, that is not a problem. It's a great question. I think one that is very important is to use something called the availability heuristic. I know Nick does this a lot in terms of the social media posts that they're thinking about. The way people think about odds and probabilities is very different than I think the way that maybe scientists think about odds and probabilities. And so one thing that we've learned from some of our work is really thinking about instances that people can think about odds. An example I can give you in terms of availability heuristic, when the Johnson & Johnson, when there was some concerns related to specific severe adverse events because of the Johnson & Johnson vaccine related to seizures. I don't know if folks remember this when this was ongoing. One of the things that we talked about is that the risk of having an adverse event related to the Johnson & Johnson vaccine is the same or less than the risk of actually getting struck by lightning. So, right, having that availability heuristic, people understand, getting struck by lightning is a very rare event is one way to do it. The second piece is to not correct the misperception. Again, I think the instinct is when someone comes to you and is the number one question I get is that I know there's a microchip in the vaccine. You tell me why I should be getting the vaccine. I think the instinct is to sort of push back on that. But instead, the third step would be to pivot the conversation and focus on severity of the disease. We can talk about the number of people have died, as Janet and Caleb have told us. We can tell a personal story, perhaps, of a community member that we know that unfortunately was not vaccinated and had severe COVID and may have passed. And the last piece is really using that default, that presumptive communication. Again, the vaccination in this country and in most countries is the norm. It's important for us from a communication perspective to focus on that and say the majority of individuals are getting the vaccine. So making the assumption that an individual will get the vaccine will also help in terms of nudging people.
Thank you. And your your recommendations were really helpful. I know I wrote down a lot of them as well. As an adolescent health researcher, I think about adolescence across 3 stages: early, middle, and late adolescence, which spans ages 11 to 24. As you know, the cognitive skills and decision-making autonomy vary significantly for a 12-year-old and a 20-year-old. Given this, how might your messaging approaches differ when targeting, say, a late middle school, early high school age student versus a college age student or a young person?
One top of mind thought comes actually from the BCHD. So the Baltimore City Health Department has really revamped the way that they've been doing health communications over the last year. I encourage everyone to check it out. But they did a strong pivot from the time when vaccines first came out and they were messaging about the eligible groups, which were largely older, more at-risk populations, to now where it's open to everybody, and the younger group is the one that's trailing in terms of vaccine uptake. And the way that they've done it is actually referring back to how they messaged it in the beginning. In the beginning, it was get the vaccine to protect yourself so you can see your grandkids. Now the message is get the vaccine so you can be safe when you see your family. And that appeals to young people, I think, more than an appeal directly to the young person themselves' health. This notion that it's for the greater good in their own family, in their communities, and for the people that they love.
I think, not have done quantitative research on this, but I am the parent of 3 teenagers. And I think that as they get into those older high schoolers and college groups, there's definitely more and more of a preference for peer learning and trusting and getting information from peers. If you're talking about young adolescents, they're still to some degree listening to teachers and parents on information like this. I think it is important to think vaccination is the norm, for the groups that have been eligible. And I think that it's not really surprising in groups where young people are living together. They see that much more readily than when they're separated. So I think emphasizing that message is important based on other kind of public health efforts.
And I would just add that sometimes I think teenagers, depending on the age, as you said, sort of maybe the slightly older ones, really should be treated as ambassadors. A lot of recycling and environmental change happened because young people told their parents that they should be doing that. And so treat them as the leaders, not as that they often will take things on, and you empower them to be change leaders and the smarter people or the next generation who's going to do something great.
So we have another question from the audience here. As we've seen more vaccine mandates go into place at different workplaces, there's been concern about folks who are leaving jobs or losing jobs if they do not get the vaccine. So how can public health practitioners support and reach out to those people who are may have legitimate concerns, who are not getting vaccinated despite the mandate, and may also be labeled, quote, anti-vaxxers. So sort of a difficult question here, but given where we are in the COVID landscape, how do we reach those folks now?
I do hate the term anti-vaxxers. I mean, you saw in our little short clip, there's something we talked about in the episode, just because it lumps in so many different things. I mean, my blood really boils when I see people on YouTube essentially monetizing some of these false claims, to gain followers and saying things that they can't possibly believe are true, spreading disinformation. But at the same time, that's not most people sharing this information. They're worried about their own health, or they just have questions. I tell you, when we crafted that episode, it was very consciously trying to reach people who had questions, who were worried about certain things. And I think that's the most important thing I would say. Obviously, I think it depends on, the intervention depends on what population you're talking about. I think nurses in the critical care unit have to be vaccinated. There's absolutely no question about it. There are probably some mandates where you could say it's a little more debatable, and maybe we should give people a little more time for this message to sink in, or think about it a little bit differently. So I think it's hard to say there's a one size fits all answer.
I would just jump in that yesterday I was in a drugstore, and a man who clearly worked in maintenance at the next door apartment had been told he needed to get vaccinated to continue working. And he came in and asked if he could get vaccinated. And the person in the store was okay, but then sort of said, well, you're a big guy, you should just do it. And what I said then, because I thought that was not helpful in any way, is that I said, it's really, you can go to the Natural History Museum, because you can in New York, and they, you don't have to pay anything. There's no line anymore. You can just go. You just need your ID. They don't ask any questions. And he was really grateful, because what he wanted was sort of an easy, helpful way, and treated with respect that he was sort of in the process of making this decision. And I sort of, to be honest, cringed at the person in the drugstore, because I'm like, that is not helpful. You're making him feel small, and he's not small. He has come to a decision, and he just wants help in getting there. So
one last quick thought on this, and I'll say right out, every single person who gets vaccinated is for the greater good of all of us. Like, every one person who gets vaccinated helps protect everyone, including themselves. That said, that particular example of Kaiser Permanente with the 2,200 workers who were suspended, we're doing a bit of what Rupali began with, where we're looking at a number without the denominator. And yes, 2,200 did say they were maybe going to not get the vaccine. They may still, and that may work, but that's less than 1% of Kaiser Permanente's eligible workforce. And so rather, I think it's important to reach these people. I think it's an ongoing thing. It'll take a lot of effort, but the eye needs to remain on the prize here, which is that vaccination is the norm for everyone who complains about maybe having to get it. Most of them will end up getting it if their workplace enforces it.
Thank you. And I believe this will be our last question. And this is a question for Dr. Limaye, and it builds on your research with church members. The question is, how did those discussions of race, health, and past, quote, experimentation feed into current reluctance to get COVID-19 vaccinations? And I'll add, what recommendations did you pull from those interviews?
Yeah, it's been really fascinating, I think, engaging with these congregation members. And I have to say, just to, I think, echo points that Janet, Nick, and Caleb have made, the majority of questions that I get are very intentional, and are because they're concerned about their health and their family. And I think what I've heard from congregation members, particularly within AME churches, were that, there's been a history of not only medical experimentation, but current racism and discrimination from a healthcare setting. And I think the problem that we're really seeing is the vaccine is heavily tied to the healthcare system. And so, it's sort of this idea of why would I trust this healthcare system that has not treated me well in the past, that doesn't treat me well now? And one thing that we have been trying to do, and we've been working with these churches, is really working with the pastors and the leadership and the elders to talk to them about, and I think Nick mentioned this as well, a piece that was done also by the school, how to talk to your friends and family that may be hesitant. So we've been spending a lot of time with church leadership of equipping them with some of these communication skills and making sure that they're clear with regards to the science behind the vaccine, so that when they do get these kinds of questions from their congregation members, they're well equipped to answer this question. But I do think it goes back to empathy in all of this. And I think that's really hard. I think a lot of people look at individuals that don't want to get the vaccine and are very dismissive of them. And, the story that Janet just told about being in that pharmacy, that's a missed opportunity, right? In my opinion, there's an easy way for us. Here's an individual that wants to get vaccinated. It's important for us across all these different types of workers to make sure that we're making it as easy as possible for them. And we're really removing any structural barriers that could be there. And so I think there's a lot of work, but I think the key thing here is thinking about who are those influencers there and continuing to work with community members that are maybe out of the healthcare system and having them really serve as the key messengers in this case.
I was going to jump in to say one thing, just because I've spent a lot of time recently on a film on Tony Fauci thinking about HIV, is that the church community was critical in changing a lot of attitudes to stigma, to getting treatment around HIV. So they have been leaders for a very long time, for many decades. So they're not new to this in a lot of congregations. They've been doing the work. And so we need to use the channels that they've already built because they've already done for decades really great work in many, many communities on the key public health issues of our time.
Yeah, I'll just add, I mean, building on the channels that are already built, I think is really important to all this work. I mean, people are scared or uncertain about something. They listen to people they talk to about other things all the time, whether they're college students or younger teenagers or people in the workplace. I mean, you go to your friend, your family, your favorite social media channels, and just that's where people go for information. They don't necessarily trust new outsiders on these most sensitive topics about their own health.
Well, thank you so much. I want to thank Kiana and Aneri for helping us facilitate this Q&A. I want to thank the individuals that joined us today for your excellent questions. And then I also want to thank Nick, Caleb, and Janet for their excellent presentations. And I think what's really critical and has been great about these presentations is that I hope that you take away from today some practical ways to move forward. If you are working with individuals that might be vaccine hesitant, how can we continue to move forward with adolescents? And so I just want to thank everyone for joining us today. It's been a really interesting discussion. I'm going to turn it over to Ann Peters from the Pulitzer Center to wrap this up for us.
Thank you, Rupali, for moderating for us today and for your own presentation. If everyone could stay with us for just a few moments longer, as Rupali said, we're so grateful for today's conversation. This is an important topic and really excited by all the back and forth, the chat, the questions. So thank you all for that. A special thanks to Brian Simpson, our Bloomberg School partner, who has led with us the organizing for this event. So thank you, Brian. And again, another thanks to all of our speakers, Caleb and Janet and Nick, and of course, again, to Rupali and Aneri and Kiana. Want to also say that we're pleased the Pulitzer Center to have supported the work of the Global Health Reporting Center. The center, along with Wingspan Productions, produced the CNN BBC Race for the Vaccine in association with HHMI Tangled Bank Studios, which also was a scientific advisor for that documentary. Also, again, a big thanks to our Bloomberg School and Global Health Now communities and our Pulitzer Center colleagues, especially Holly Rosewood, who produced today's event, and Kayla Edwards for assisting with the Q&A. There's more great reporting as well at Global Health Now and at the Pulitzer Center, where you can also find out more about how you can become a Pulitzer Center champion. We have a brief survey that we hope you will check out. It's short after we officially end today's session, and it will help us learn more about your thoughts on today's conversations and how we can develop future programming. And with that, I just want to again say thank you for joining us and goodbye for now.